Good evening. Welcome to the second webinar in the PSC Partners Seeking a Cure 2020 conference webinar series. My name is Mary Vyas, and I'm the president of PSC Partners Seeking a Cure Canada. The title of this webinar is Update on COVID-19 for the PSC Patient, What You Need to Know to Navigate Through the Latest Information. This webinar will be focused on bringing the PSC community as much information as possible to help navigate the many choices we are facing as we enter a new phase with reopening, returning to work, and resuming more usual activities. During these incredibly difficult days, we're so grateful that you've taken the time to join us. We will be recording this webinar to make the information available to those whose attention is elsewhere this evening. All right, let's get started. Can we launch the first poll, please? We'd like to take a poll to see who is here. Please take a moment and respond to the poll by indicating if you are a PSCer, spouse of a PSCer, parent of PSCer, other caregiver, or other. And while those responses are coming in, I'd like to review a little bit of webinar logistics. You are attending this as a viewer. You can see and hear the speakers and moderators, but we cannot see or hear you. The speakers will be taking questions throughout the hour we have together. So please enter your questions at any time into the Q&A box. The Q&A feature shows up differently on different devices. On my screen, it shows up at the bottom, the center, at the bottom of my screen. You may need to hover your mouse over the bottom of your window to see it. Please keep your questions general, and for personal advice, as always, speak to your PSC specialist. The speakers will respond to as many questions as they can. If they do not get to them all, please check back with us when the video of this webinar is posted. Our speakers will be trying to answer as many of the unanswered questions as they can, which we will then post on our website alongside the video. Okay, so can we see the poll responses? All right, so we have 53% of us are PSCers. No spouses are here tonight. We have 35% parent of PSCer and a few others. Thank you so much for participating. A very warm welcome to all of you and to our speakers. I'll turn things over now to Ricky Safer, CEO and founder of PSC Partners, to introduce our speakers.
Thank you to everyone for joining our COVID-19 update webinar tonight. This is a follow-up to our first COVID webinar, which was held on March 19th, when very little was known about the behavior of this virus. In the past 2 months, we as PSCers and caregivers have tried to keep up with the dizzying pace of new scientific information about every aspect of this virus. We've closely followed the steps being taken to combat the pandemic internationally. Personally, I'm often overwhelmed by the conflicting information in the news outlets and social media. Our three experts tonight will sift through the most current available information that affects us as PSC patients and will share their insights and opinions. Before starting our program tonight, here are a few brief organizational updates about our programs that might be of interest to you. For PSC patients who have had COVID-19, please fill out our survey, as your information will provide valuable data about the impact of COVID-19 specifically on PSC. You will hear more about this survey tonight. We hope that you're enjoying the new format of our recently launched website. If you haven't yet joined our mailing list or our social media groups, please go to pscpartners.org to find out how to keep in touch with us. Check out the COVID-19 page where the information is constantly being updated. In July, we are planning to continue our annual conference webinar series with speakers from our original April agenda. We've kept an important element of our conference, the peer group meetings, which we have replaced with Zoom room, small group, casual get-togethers. On June 11th, we will have a Zoom room for parents of pediatric PSCers. And on June 27th, we will have a Zoom room for adult PSCers 40 and over with separate male and female groups. And as always, I'll remind you that if you haven't yet joined our patient registry, please participate. The format we'll be following this evening will be comprised of a combination of short presentations mixed with Q&A, using questions coming from our community. some of which were sent to us prior to this evening, and others which you'll be sending in tonight. Our speakers will cover a variety of relevant COVID topics for PSCers, including special considerations for both pre- and post-transplant patients, the state of COVID testing and the significance of test results and vaccine development, accessing healthcare and clinical trials during the pandemic, and your personal risk assessment. Mary Vyas will talk about the PSC Partners COVID-19 survey for PSC patients. Please send in your questions, as Mary said, via the Q&A function at the bottom of your screen, and the speakers will do their best to answer as many questions as possible. This webinar will be recorded, posted on the COVID-19 page of your screen, of our website, I'm sorry. Before introducing tonight's speakers, I would like to ask all of the attendees to please respond to two other polling questions. First question, which of the following precautions are you following? And it's multiple choice, so you may list as many as you'd like. Self-quarantine, shelter in place, physical distancing, mask when you leave the house, mask in a crowd only, consistent hand washing, none of the above. Please send in your answer. Looks like we have the answers. So 41% of the people are self-quarantining, 65% are sheltering in place, 92% are physical distancing, 68% are wearing a mask when they leave the house, 24% wearing a mask in a crowd only, 84% consistent hand washing, and 3% none of the above. Good answers. Thank you. All right, one more poll, please. For this question, during the COVID-19 outbreak, have you had a, and again, multiple choice, telehealth visit, in-person appointment, MRCP, ERCP, or colonoscopy? Please submit your answers. All right, here are the answers. 84% of us have had a telehealth visit, 47% an in-person appointment, 16% MRCP, 0% ERCP, and 3% colonoscopy. Okay, thank you. All right, now I would like to introduce our expert presenters and thank them for sharing their wisdom with us. Tonight's moderator is Dr. Steve Rossi, PharmD, who has been doing pro bono consulting for PSC Partners for the past 5 months. He brings us a wealth of experience from the pharmaceutical industry. Dr. Gideon Hirschfield is a hepatologist at the Toronto Center for Liver Disease and director of the Autoimmune Liver Disease Program. Dr. Hirschfield is a member of our Scientific Medical Advisory Committee and for years has been passionate about finding new therapies and a cure for PSC. Dr. Cynthia Levy is a hepatologist at the University of Miami. Her research focuses on developing new drugs for the treatment of PSC and other autoimmune cholestatic diseases. She, too, is a member of our Scientific Medical Advisory Committee and a longtime collaborator with PSC Partners. Steve, would you like to start the program?
Yeah, thank you very much, Ricky. First of all, Gideon and Cynthia, thank you so much for making time for us tonight. As Ricky highlighted, there has been a storm of new information even since the last webinar that was done a couple months ago. So even things that we answered previously, as recent as today, there is new information that comes out. So I think one, we'll talk a little bit about sort of where things have progressed, but I think most importantly for the community, it will be great to hear your thoughts on all the information that's out there. And importantly, since you're working so closely in so many areas that we're talking about, provide your expert opinions on where we're at. I think one of the first things we want to dive into as we move more towards reopening, we had very sort of loose restrictions and safety or very minimal safety requirements up front. Things got very strict. And now we're sort of at a crossroads of how do we adjust to this new world and how do people re-enter safely into a normal life based on their local guidance and also medical. Cynthia, it'd be good to hear from you sort of how you're seeing patients re-enter and the advice you'd give to patients about safety, masks, things like that as they head into the community again.
Thanks, Steve. Good evening, everyone. And I'd like to start by thanking Ricky and all the leadership for PSC Partners for inviting me to participate. This is a great question. We were just talking about how we in the healthcare system, so the providers, we are getting ready, we are being trained, and we're phasing in again, but the patients are not ready to come back. You guys need to hear more from us and hear that it's safe, it's okay to come in, and how to do that. So that's a great question. Sorry, my Alexa decided to respond to my comments. Anyways, so what's important? Well, in terms of safety measures, we'll continue with the same safety. So we should still practice social distancing, right? The 6 feet is not just a magic number. It's really important to prevent the transmission as a prophylaxis. We should be wearing masks when we go to public spaces. I don't think we need to wear them at home, but yes, when we go to public spaces, especially if you expect a crowd or places where it's difficult to keep the social distancing, like the supermarket, for instance, or if you have to go to the lab, or if you have to go to the clinic, to the hospital. So you should be wearing a mask. Wash your hands frequently for 20 seconds, right? So they say sing happy birthday while you're washing your hands. That's the best thing, to wash your hands with soap. It's after you go outside, especially. If the water and soap is not available, then you can use the alcohol gel and do that to sanitize instead. Also, you can clean your work surfaces, disinfect frequently. That's really important. In fact, I think CDC has recently sent out some recommendations as far as how to prepare your workplace for you to come back. So it's not just how do you go back to healthcare, but how do you go back to your life? How should your office be? And exactly, the new office space will have to keep the same distance or put barriers between the cubicles. People will have to wear face masks at work. And there will be symptom and temperature checks in and out when you come in. So this is what our hospital is doing to make it safer for the patients and for us and the clinicians. We do have screening, so when you come in for a visit, we'll be asking about your travel history, we'll be asking about symptoms, we'll be checking your temperature. No visitors are allowed, just the patient will come in, all to minimize contact. So I think I answered your question. And there are a lot of other safety measures in place in healthcare also to prevent that transmission and make it safer for you.
Gideon, if you can take yourself off mute, I think. There we go. Gideon, from your perspective, is there anything specific or different for PSC patients? I think Cynthia highlighted, I think, a really good broad population perspective. Do we do anything different for PSC patients just because they have PSC?
So that's a very good question, Steve. I mean, what I'm telling my patients is first and foremost is our patients are special. They do have different needs. Some of them have inflammatory bowel disease and some of them are sicker than others. But largely the risk factors for having a bad outcome from COVID are not related to having PSC or having inflammatory bowel disease. And so I'm really encouraging them, just as they cope with living with PSC, to recognize that this is not going away. This is with us for the duration. There may be waves of infection. And so we're all going to have to adapt and find a new normal, exactly as Cynthia said. So I don't want my patients to lose sight of their lives or their medical needs. I want them to recognize if they are on immunosuppression, that might be a small risk factor. But really I'm focusing the very significant shielding advice to the patients who I think are quite sick, the patients who are really probably waiting liver transplantation. And I'm very worried that I don't want the majority of patients to miss medicines, miss follow-up, or stop surveillance, because we're going to have to live with COVID, and COVID we need to make a minority part of our healthcare so that the majority part of our healthcare can go on. And we also know from living with PSC that the minute we make our medical problems the sole thing that we focus on, it's not healthy. And And that's a really, I think PSC patients know that more than most. They live with PSC sometimes for 20, 30, 40 years. And they need to be successful in everything, not just their PSC. So I'm trying to get my patients to take a moderate approach. I've encouraged them exactly as Cynthia said, physical distancing, a mask when they go to the shops on public transport. They have to wear a mask when they enter a hospital. It's just the rules now. But also that they can go and get their bloods done. They can get their MRI done. We will be reopening colonoscopy, and we will want them to have surveillance. And we'll have to trust in the hospitals, and and the hospitals are putting a lot of thought into this, how to make it as safe as possible. Equally, their kids are going to want to go back to school, whether the kids have PSC or they're the parents of children, and it's essential that we let them do that. Otherwise, this long haul, which may go on for many years, we don't know how soon a vaccine will come, will really wear us down beyond the impact of COVID itself.
That's great. I think you brought up a point that came up from several of the community members of how do children fit into the balance of this, both as potentially a parent of a PSC child, but importantly, we got several questions. Is there something unique I need to do to either protect my children when I'm coming home from work, or do I put limitations on my children if I've got PSC on what they can do?
Yeah. Children are exceptionally low risk. Yep. And in statistical terms, nothing will happen to your child if they get COVID. Yeah. And that's probably also true if they have PSC, and probably the only children with PSC who are really ones we're going to worry about will be the ones waiting for a liver transplant, or who have just had a liver transplant in the last 6 months, who haven't yet sort of become a sort of stable post-transplant patient.
Cynthia?
But our children per se are low risk.
Yeah, Cynthia, your thoughts?
No, I completely agree with Gideon. They are low risk. Just we have to keep in mind that they may be asymptomatic. They may carriers, let's say that way, of COVID, right? Yeah. So even if they are not going to have, so your kid with PSC will be fine. But if you have an adult with PSC, or any adult for that matter in the house, that kid could transmit the disease. So I think my personal approach is, even though they are low risk, I would still impose all the restrictions that we have for the general population with the social distancing. I wouldn't let them go play with the kids around the street, because you don't know what they will bring back home. Yeah. So I'm not ready to do that. In the house, there's no reason. Let's say, I saw a question, let's say somebody has 3 or 4 kids, one has disease, the others don't. Disease, I mean PSC, the others don't. You don't need to keep them separate, right? Everybody in the house will live together. But as far as what measures they should take when they go outside, I would say it's the same as for the adult, in my opinion.
And I think that's going to evolve over time, but I think for right now, that's kind of, people are asking, we're at this crossroads, how far can I challenge or move on? And I think to Gideon's point, we are looking for some sort of normalcy, and it's good to find that balance.
I guess, Steve, one more. I think you also have to take into consideration the number of cases in your particular community or city, right? If you are in an area that's very high, that you have still a lot of cases coming up, then you have to be extra cautious. Whereas if you're in a place where there are barely any cases, and in Florida, for instance, we have this huge discrepancy in my county. So Miami-Dade and Broward, there are thousands of cases, whereas if you go 3 hours north, there's sporadic cases. So that family may feel more comfortable going to more crowded spaces and following the precautions than we would feel in Miami. So you have to be aware of your surroundings.
I think that's a good point, in the local jurisdictions and guidances, even from the governments. I think one of the things that was brought up in the polling questions are procedures. I think the biggest thing that patients are wondering, some of them are getting letters saying you've got to follow up, a standard format letter, and they don't know, do I follow through with that or not? Are there, where are you both on the scheduling of, in particular, routine? There will always be the emergent procedures, which I think everybody agrees should happen. if possible. I think it's more the routine monitoring procedures like colonoscopy, EGD, things like that. Where do you think we are right now in being able to do those safely?
So I can start from my perspective. We only had a temporary hiatus on MRIs, and I'm pleased to, now say that my inbox has already got 9 MRIs waiting for opinions, which is good. So our patients are getting their MRIs on schedule. Again, we're about to reopen endoscopy. I think it's safe for you to have an endoscopy. In our program, in fact, you'll be screened for COVID before you even get your endoscopy. At current, that's the plan. But that will take a bit of time. But we are pushing that basically a lot of the colonoscopy and endoscopy should be start to go back to normal schedule. But there will be a bit of delay. I don't know what it's like for Cynthia, but we're going to see there is going to be 3 to 4 months of catch up. I don't think that's terrible. I think you'll find that most clinicians are really carefully looking at their lists and making sure the patients who really can't wait go first. Most endoscopy programs, either in hospital or in the community, are working very hard on reopening. Our patients are getting their lab work done normally at their local labs. So we've tried very hard actually to start catching up. And I think the only thing that will take a bit longer will be the endoscopy, because of the number of procedures that some endoscopy units will do per day will go down. But largely, I think it's okay for patients that there might be a little bit of delay, but I'm reassured that essentially the message is clear and the hospitals have agreed that we have to reopen.
Yep. Cynthia, how is it going in Miami in terms of that?
Yeah. So as far as labs, yes, patients can go to their local lab or to our clinic. The local labs have provisions in place as well. They schedule the patient for a certain time. Patients wait in their car, and when it's their turn, they get a text, they go in. So that minimizes contact with other patients who are coming in. So it's only a one-to-one basis when they're inside the lab. So that is one thing. As far as, MRIs, that really never stopped, but it slowed down. Every week I got a list of all the cases that I had ordered, and I had to prioritize them. So I chose to maybe delay some cases, but in the end it wasn't a huge delay, and we are catching up as Gideon said. So with MRIs there hasn't been a great delay. The whole place is sanitized between patients, and so it's a slower turnaround. With endoscopy it's a bigger problem. We actually opened up about 3 weeks ago for semi-urgent cases. And the definition is open for us to interpret how we want what's semi-urgent. But it started about 3 weeks ago. And then this week we started even with routine cases. So screening and surveillance of varices, surveillance colonoscopies, all of that we are already doing. Patients are asked to come into the hospital 2 days before. They are all tested for COVID. And of course, if they're negative, they don't get the test unless it's an emergency, and then the COVID is dealt with. If they are negative, they come in. And even with them being negative, we all wear full gear, full protective, personal protective equipment. And actually, our endoscopy director devised some plastic coverage for the patient to minimize exposure for all the providers around. So we are catching up, but because of all of these measures that are in place, the turnaround is super slow. So we take 5 minutes to do an endoscopy, but we wait 1 hour between cases. And yes, Gideon is right. We're doing half of the cases, the number of cases that we usually do, and there will be a backlog. We are being asked to scope on the weekends to catch up, and that's the change that is to come. We have to prioritize every week. Again, we get a list of our procedures and we decide who must have it first. So we are back. The clinics are open with reduced number of patients, no overbooks allowed. We're keeping a small number of slots for telemedicine for the patients who don't feel comfortable coming in or who can't come in for whatever reason. So slowly we're picking up with those restrictions that I mentioned in place.
Okay, good. I think, you've given a good perspective that we're on our way to getting back to some normal sense of healthcare, being able to support patients, but there's still some ways to go. I'd like to move us, because we've got a lot of questions, and also I think there's been some new information that's come out of sort of the relationship of COVID-19 and liver disease, along with some of the medications and the populations, and are there different risks or things that should be done? There's been several studies that have come out recently that said patients who have more significant liver disease have poorer outcomes, in particular cirrhotics or more advanced disease than maybe the general population. It's a little confusing because some people are thinking that means that if you have liver disease, you have greater risk of getting the infection. It'd be good to get your guys' thoughts on where does the risk of infection versus the risk of an outcome with background liver disease differ, and kind of give your thoughts on that. Cynthia, do you want to start? Because I know that you.
Sure. Well, I agree with you. The data is scarce and conflicting information. Some studies, most studies actually do not show that a patient with liver disease is at increased risk for infection. And I'm not convinced that that's the case. I'm interested in hearing what Gideon will say. I don't think just because you have a liver disease, you're at increased risk of getting the infection. Possibly if you're on immunosuppression, you may be at an increased risk, but then it's the immunosuppression, it's not the liver disease. And that doesn't necessarily put you at an increased risk for severe infection. We thought it could. I think early on, as we knew less about the disease, we thought, okay, if you're immunosuppressed, you're at risk of a more severe infection. But we're learning that it looks like the host immune system actually plays a role in the severity of the lung inflammation. So it's not, the studies that are coming out are not really showing that patients on immunosuppressants are necessarily at higher risk for severe infection, unless they're on high doses of prednisone, or if it's a cirrhotic patient on high dose of immunosuppression, those patients may be at higher risk for infection. The most recent study, actually, so I think it was just came out, it's an international perspective, 150 patients with chronic liver disease, and it's just observational study, right? So there's no control group. But just looking at these patients and their natural course when they were hospitalized or infected with COVID, they developed COVID, it showed that patients with cirrhosis, there is decompensated, so child B or C, those patients who have ascites, patients who have bled, patients with encephalopathy, so more advanced disease, these patients tend to have a poorer outcome in the hospital. But a well-compensated cirrhotic patient is not necessarily at a much increased risk, I think.
Yeah. Gideon, I mean, your thoughts? I agree, Cynthia. The data has been a little conflicting both ways. Yeah.
Look, I think the way to look at it is that your risk of acquisition, in my opinion, is not related to your underlying disease. And the only reason that some patients will be more at risk of catching it will be if they're very sick and they're frequenting, for example, places where they could catch it. So if, the populations like the renal dialysis patients, it's very difficult for them. They have to go to hospital 3 times a week. And that's, they're engaging with healthcare. If you have different needs and you're having, say, carers coming into your house every day, there's your risk. So I don't think your risk of acquisition relates to something intrinsic to yourself. I think it relates to your system interactions. Okay. And then my reading of the literature is pretty simple, that I think your outcome for COVID is largely determined by your age, and gender seems to play a role. And then, of course, anyone who is sick, who then gets sick again on top of that, will have a bigger journey to follow. And so if you have very significant liver disease, it's never a good time to get pneumonia. And whether it's COVID pneumonia or influenza pneumonia, it's never a good time to get it. And that's the reality. We don't know everything. Many of our patients have shielded very effectively. So we can't be completely confident, because some of the lack of acquisition may simply be that they haven't gone out. And the second thing we don't know really is, we've discovered despite what all the clever epidemiology doctors told us at the beginning, half the time you don't even know that you've had COVID. So there's almost certainly a huge asymptomatic burden, which means the denominator is much bigger than we thought in terms of the impact. That's not saying that COVID isn't important. That's not saying that the burden of COVID is not important for healthcare to manage all at once. But it does come back to that question that on an individual basis, your individual risk of COVID, if you're, under the age of 60 is very, very low on a personal level. And the truth is your risk really goes up by most significantly around age.
Can I say there's also another group that we can't forget, and that is related to liver disease. I think what I'm seeing a lot, not only in the literature, but with clinical experience, obesity is a major risk factor for poor outcomes in this disease. So males, older, but if you're obese, even the younger guys, diabetes out of control, COPD. So the fatty liver patients tend to have a lot of these factors. They may be at an increased risk of developing severe disease. Yeah. Right. So that's a group to keep in mind, but I don't think that's
why we all have to get out the house.
Yeah, exactly.
Yeah, exactly. Exercise.
Bad diet, not enough exercise. Yes. And that's exactly what COVID wants.
Yeah.
And so, that's why we have to reassure people that they can go out, get some exercise, and get back to healthy lives, because otherwise you're doubling up your risk unwittingly.
Yeah. I think those are good perspectives on how to look at the overall data, but there's some things that have come up from a couple patients that they've have brought up that they would like to get some specific insights to. First of all, the transplant population you've brought up several times is unique because they're on medications that potentially could at least alter the immune system. Can you talk about the latest guidance on what should be done, if anything, with transplant immunosuppression, things like steroids or other meds, or is it stay the course because there doesn't appear to be an impact? And the second part of the question is, given that some of these drugs suppress the immune system, could they actually be helpful in blocking some of the cytokine storm? That came up, a couple of patients wondered that for both transplant and autoimmune. Gideon, do you want to start?
Well, look, you may guess from my general approach to things, pretty much I'm a pragmatist, and I don't think that anyone who is stable post-transplant should be adjusting their medicines because of COVID. I don't think that any patient post-transplant, COVID or no COVID, should ever be on too much immunosuppression. And I've always been someone who works to get patients on the lowest burden of immunosuppression because generally it's safer. Does that mean doctors will be practicing slightly differently? Yes. They will have a higher threshold to treat rejection. They will have a higher threshold to say, I want to increase your immunosuppression. They might be that little bit more thorough. They might do a few more biopsies. Sometimes, you look at someone post-transplant, you look at the liver test and you say, you know what, I think you need a bit more. Actually, maybe now what I might do is get the biopsy and be absolutely sure that you really do need a bit more, rather than just dial it up, dial it down. Okay?
Cynthia, what do you think on that?
Yeah, I in general terms, I agree with Gideon. I think there's most guidance documents, so ASLD, ISO, and individual institutions will not change the immunosuppressant even if you get COVID. So then the recommendation is don't change it. For the more severe case, so I can tell you in my institution, if you're post-transplant, being liver, multivisceral, kidney, if you're on CellCept, there is a tendency to cut the dose by half. Not so much because of the immunosuppressant effect, but the mechanisms of action for CellCept are a little different, but the other doses are kept the same. If a patient has severe infection, then we lower the dose of the other immunosuppressants, or sometimes we hold them. But that's the same that we do if you have a patient with sepsis in the hospital who is post-transplant and is on immunosuppressants. We have sometimes to hold the immunosuppression to save their lives, and then we resume because that's more important than the liver in that moment. But it's not different for COVID.
Yeah.
So the recommendation, and for autoimmune hepatitis, we do not touch their immunosuppression. There is no recommendation to change that. There are already a couple of studies showing that these patients don't seem to be at increased risk for infection or severe infection. So we should not, well, I think the only contentious point maybe to avoid high doses of steroids. But other than that, we don't change the management.
Yeah, so similar to what Gideon was saying, you may delay on pulsing somebody for rejection or using a big treatment of rejection right at the time. Moving to another because there's three sort of buckets of populations that have come up that people have questions about. The other is the IBD patient who is on biologics. And there does seem to be a movement around some concerns about using like Humira or some of the other biologics in the setting of COVID-19. Not both maybe from a risk, but also obviously if somebody's got the infection. Any thoughts on that perspective?
Well, look, again, I think it depends on whether you got COVID or you're at risk of getting COVID.
Okay.
And that, again, what Cynthia was alluding to when she talked about post-transplant immunosuppression was only what at the point you got COVID. And yes, if you get COVID, you become lymphopenic, your white cell count drops. Of course, you're going to hold the azathioprine or the Cellcept. And I think it's the same for IBD. I think if you're stable on IBD and you don't have COVID, you don't really want to change your medicines. I think if you don't have COVID and your IBD flares and your drugs are not working, you still want the best treatment. Okay. Now, we always look at the risks and benefits. And for example, I'm always a bit more cautious about using anti-TNFs, Humira, in someone who's got very advanced liver disease, as opposed to maybe using vedolizumab or Stelara. And that may just be me interpreting data, but that decision-making process goes on anyway, COVID or no COVID. If you get COVID, then you're managed as an individual based on the severity of your COVID illness. And for the majority of people who get COVID, they're going to have it for a week or two, and that won't impact if they were to pause their medicines for 2 weeks because they're sick with a viral pneumonia. If you end up in hospital, you're unlucky, and you've got a very severe COVID infection, then of course, just as post-transplant, the likelihood is that some drugs will be held because the priority changes, and the priority becomes that management of COVID sepsis. But the management of COVID sepsis is evolving. And as you alluded to, we don't quite know at which point in COVID sepsis to give anti-inflammatories, actually because the COVID is causing a massive inflammatory response, particularly in the lung. Yeah. And we're getting better at it, and your intensivists and your internal physicians and respiratory and ID doctors are getting a better feel for who they're using those approaches to. But we don't have all those answers. So I think, again, you're going to have to put the trust in someone making an assessment around you, and you need to try and resist the temptation to change what's working for you, even if you get COVID. And you have to be assessed at the time rather than trying to think that there's a perfect answer for every question.
Yeah. I think what you're bringing, because we'll move on to the next section, you're bringing for both of these, you both have highlighted something, is that you shouldn't be adjusting either your transplant meds or your IBD meds, one, on your own because of a concerned risk, and two, the risk really comes up when you get, in particular, more severe COVID, and that will likely be managed as it would for anybody who's severely ill. So I think keeping it that it brings a new twist to it, but it really isn't managed any differently than we would manage anybody else with a severe infection.
And a really important point, Steve, I'm sure Cynthia agrees, now is not the time to be having emergency surgery. Flare,
and it becomes
resistant to medical treatment. Yeah. Because the combination of having COVID pneumonia and an emergency laparotomy is not a good combination.
Yeah.
And that's why those of us who are not on the front line in terms of managing COVID are actually, we think, doing quite an important job of keeping people away from the ER, keeping away from getting sick. And it's why we've been advocating behind the scenes so hard that although it's difficult, they have to reopen. Because allowing our patients to become out of control will actually make it harder for them, not easier for them.
Okay. Well, listen, because we're moving as we expected, we're moving through our time fast. The good thing is we are able to go over a little bit, so people don't worry. We can go over 5 o'clock a little bit, or I'm saying 5 o'clock West Coast time. But if we can, Catherine, we're going to move into some of the presentation on some of the information and go through some of those questions next. So if we can pull up the slides. I'm going to be doing some brief presentation here on where there's been a lot of new information, and most importantly, where a lot of questions have come in from the community. And I'm going to present sort of a high level on each of these topics just to kind of bring us to where we are, at least even as of today, the most current thinking. These slides have a lot of information on them. We created these specifically so that they could be referenced and you can go back to them after the webinar and actually go through and read them. So don't worry in trying to read everything on the slides, and I'm going to highlight the key points and also bring in both Drs. Hirschfield and Levy to give some of their perspective on it. But these slides will be posted on the website along with the link to the webinar in case there's questions afterwards. If we can go to the next slide, Catherine. So the first thing I want to touch base on is the whole issue of testing. And testing gets labeled as a broad term. Everybody says, I need to go get tested for COVID-19. But I think we've really advanced, and most people are out there are aware, there are really two different ways we're testing for different aspects of the COVID-19 infection. The first test that was actually developed was the COVID-19 virus test, and that actually was developed to detect very specific parts of the actual virus itself. And what it was and still remains most useful for is determining if somebody is actually currently infected, and in particular, it's important when somebody's been identified as being infected, they still remain contagious. And it's been a good trigger for deciding when we may want to quarantine or self-isolate other people who have been around somebody infected. As many of us know, these tests took a long time to develop and get actually out there. But as of current, the current tests that we're using for measuring the virus are very effective and actually can give very rapid turnaround times and results available. In some cases, you can get at the clinic results the same day, but in most cases, it takes about 1 to 2 days to actually get the results back. If you look at the picture below, you can see that the way the viral test is actually collected currently is through a nasal swab. So it does, at least for the most of the time, require you to go to a place that can actually do a nasal swab collection. There are some at-home kits that are being developed to do this. We still haven't seen how much those are being used and how reliable they are, but they are out there and being used. But for most part, I think people are still recommending to go to a good testing site to actually collect it. In the future, there may be other ways, such as saliva or other things that might be able to be used. You can see then when the viral test actually starts to increase, and that's usually a few days before if somebody's going to be symptomatic. It generally starts to go up a few days before symptoms actually happen, and starts to actually, the virus replicates inside your nasal and lungs, and eventually will start to go down over time as the infection hopefully improves and your body starts to fight the infection. Now, here it says that the virus generally goes down over a 2-week period, and that is representative for the majority of patients. But there are cases where patients are very sick and that the virus may persist for quite some time. But in general, it goes up a few days after infection and it peaks out generally at the time of symptoms, and then will start to go down over time. So again, that's really used to say, are you infected? And most importantly, are you potentially contagious to other people who are around you? Now, the second test has been a little more challenging, which is the antibody test. And what the antibody test actually measures is how your body is reacting to the virus. So it is not something that actually determines, are you acutely infected, because it often doesn't start to become detectable until after after you've been infected for at least a week or so. It's usually 5 to 7 days. Those antibody levels will pop up, and they're measured in the blood at this point. What it really is being used for is to determine, have you previously been exposed to the infection? A lot of places now, when you go to testing, will actually do both at the same time. Even if you want an antibody test, they frequently will test you for the virus first, and then will actually test the antibody. A lot of clinics are starting to do that because you can see you may get caught in the middle of where a viral load is going down and the antibody test hasn't quite come up. So the two tests are measure two very different things, but they're both important in helping us understand not only the potential for being contagious, but also potentially, have you been exposed? And we're hoping or trying to understand, does it confer some sort of, are you immune to reinfection? Now, if we go to the next slide, the challenge is that there were at one point over 100 antibody tests that were made available through emergency use. Fortunately, the FDA has stepped in and actually have posted on their website there are only 13 tests that currently meet the FDA standards for routine use. And the good news is, at this point, most of the major labs and hospitals and clinics doing testing are using these tests. And the main reason these standards were set up was really trying to make sure that the tests were accurate. And you want to decrease the chance of what's called a false positive, which means that you actually, the result is positive, but you actually don't have an antibody there, or a false negative, which would mean it says you don't have an antibody, but you actually do. And these two things could actually complicate how you may carry out your assessment of risk, or kind of think about whether you should continue to stay in shelter, or a variety of risk prevention. I think the one thing that's important to highlight is that, given what we know with the antibody test should not be used at this point to determine, do you change your risk behavior? There's still so many unknowns that are out there at this point. One of the things that we do have is that there are several things that are still unknown about these antibody tests, and these are the big questions that remain out there. First of all, if you do have a positive antibody, does it mean you can't be reinfected? The second is, how long do those antibodies stay in your blood, and do they need to be at a certain concentration? If they do protect you, do they need to be above a certain level? And the other aspect is, many times these antibodies disappear over time, but if you see the virus again, it will pop back up. We don't know how that is going to play out at this point. So there is still a lot we don't understand about the antibody test. So it's an important test to help us understand what's going on with the infection, but we need to be real careful in using the antibody test to make any decisions on how we proceed with our safety at this point. Cynthia or Gideon, any thoughts on your perspectives on antibody testing in particular?
Not very useful for patients at the moment, in my opinion. It's mainly really helping us understand the infection and understand how much of the community has been exposed. We haven't lived with this for even one season yet, so we don't have the feeling about whether it means it protects you, does it, and we'll have to learn that. I'm quite sure that, if you get it now, then that's fine for this season, but that doesn't mean for next season, and the next wave. So, I would, I think patients can use it out of curiosity. I think there's many of us would like to know whether we have had it. And when they've done the antibody testing in healthcare providers, it's been quite insightful that a large number have had it and didn't know about it. But it's not going to be your green card to saying you'll never get it again, or as you say, you don't need to physically distance or contribute to that new way of living so that we reduce the chance of the spreading at a pace that we can't control.
There's also a lot of cross-reactivity with other coronaviruses. So if you have the antibody, you don't know really what you were exposed to. So this virus is part of a family of coronavirus that is not the COV-2, so different coronavirus that can cause common cold, for instance, and other types of infections. So maybe you've had that and you developed the antibody and now you don't know which coronavirus it was. So I agree, we cannot rely on that at all. Yeah, it's interesting. So we participated in a research study at my institution. They were checking the healthcare providers. Me and my husband were tested, and he's positive for the IgG. I'm negative. Like, how is that? And we're both asymptomatic. So we don't know. Let's see. We have a lot to learn about above what cutoff value do we consider that really a positive test, and if is there anything to differentiate this from other coronaviruses, we still have to learn.
Yeah, I think the good news is, because I was having worked in diagnostics, it was a free-for-all when all these antibody tests first came out. There were tests that had accuracies or sensitivities of less than 80%. I think they've improved significantly, so we are getting better information. And most of the big labs are using the more reliable ones at this point.
There's so many tests being developed, and we're looking at point of care. So pick the finger, and in 15 minutes, you're going to have a qualitative PCR. So real time to know whether or not you have the virus. That will be very helpful when it's fully developed.
Interesting question came up from one of the community members that right now they're having to get an MRI. They're actually having to get tested 2 days in advance to show that they don't have an active infection. Is that standard at your guys' institutions?
We are. At the moment, not for MRIs, no. For any surgical procedure and in endoscopy, they are potentially testing patients.
Same here, just for endoscopy, not for MRI.
Okay.
But it's not clear whether they'll keep doing that. At the moment, it's something like less than 1% in, certainly for where I work in Toronto, of the patients who are being screened for a procedure coming back with PCR positive. So I don't know whether that will continue. It makes sense, I guess, to try and reduce hospital-acquired infections. It's now much easier to get the test, but for some of our patients, it means a journey into a specific place to get the test. Yeah. So logistically, for patients, it's a bit of a burden, actually.
Yeah.
Plus, I don't understand doing it with the MRI where it's not a high-risk situation. You're not coughing. You're not being intubated. The droplet exposure is not as big, so it doesn't make that much sense. That is very institution-dependent. Yeah. Same thing in our institution, Gideon. 400 people tested, 1 positive. Patients being tested before endoscopies. 400 patients, 1 was positive. And we still use PPEs and everything for everybody.
Yeah.
400 patients were to find time to go and get a test, probably from a very specific provider, so that you could have the results in your hospital system rather than going anywhere that they choose because you wanted it to be done within 48 to 72 hours of the test.
Exactly.
So these things will evolve as we get better at it. And there's a lot of things that are being talked about, and at local levels, there are different political issues and different risk-benefit assessments being made.
Okay. Catherine, can we pull the slides back up? Because we'll go on to the next, we'll move into the medications, because it seems like every day we get a new study, including today, 3 notifications on different studies for the medications. Can you pull those up? All right. So what I'll present a little bit is in particular about 2 of the medications that there's been a lot of interest and a lot of questions from the community about, but also, frankly, in the scientific world, seems to be where there is a fair amount of debate as new data comes out. I think the first thing that's important to understand is we have seen a acceleration of clinical studies for this pandemic like nothing I've ever seen in my career, including through other major, what would be considered accelerated drug developments such as HIV or other areas. As of yesterday, there are over 400 industry-sponsored studies just on drugs and vaccines for COVID-19 globally. There were another 1,500 investigator academic COVID-19 related studies. So this is just, we've never seen the kinds of activity, but also we've never seen the types of collaborations we're seeing between investigators, the governments, World Health Organization, NIH, and all coming together to try and find answers to better understand how we can treat patients with COVID-19 better. One thing, though, that's important to understand, because there's a lot of information, lots of press releases about new medications being studied, but from a high level, there are two real big buckets of medications. The first are those that actually work to hopefully either stop the virus from replicating or stop some of the direct activity of the virus itself. And these include drugs that you've heard about, the most recently approved remdesivir, information also on hydroxychloroquine and azithromycin also is an important aspect we'll talk about. And then there's other medications that are in earlier stages or have been studied, maybe not showing the same degree of effect, including antivirals for HIV and other viruses. There's a lot of focus on new antibodies that might actually attack the virus specifically itself. And then even of great interest is actually using what's called convalescent plasma, which is basically plasma from patients who have been infected to try and see if their antibodies actually and other things maybe in their plasma can actually attack the virus. The second part, though, is as we've talked about, there are a lot of secondary consequences of the viral infection. So even if the virus eventually goes down, it triggers, in particular, the most serious thing, which is this cytokine storm that is causing the injury to the lungs. And so in those settings, we're looking at, in particular, specific immune therapies, many of which have been used to treat, in particular, rheumatoid arthritis and other autoimmune diseases. We're looking at other drugs that are specifically dealing with fibrosis or inflammation in the lung. Nitrous oxide has been looked at, and then sort of supporting the patient's complications. As we've seen, these patients can actually go into bacterial pneumonia and need antibiotics. There appears to be coagulation issues, so blood thinners are being used and studied. But in general, it's important to understand that these really, at this point, have been studied sort of separately. I think what will be interesting is we're starting to see some studies go forward that are combining therapies against the virus and therapies that can help with the complications. Next slide. Now, the one that's got a lot of attention lately, and that actually has, even as of today, had some new information come out, is hydroxychloroquine. And hydroxychloroquine is a drug that actually is approved for a variety of other malaria, lupus, and even rheumatoid arthritis. I think what's important when we think about even the use of it is there are patients who actually need this medication that in the early stages were actually having difficulties accessing it because there was a run on hydroxychloroquine and people trying to get access to it. Now, all this came from a very small pilot study that was done in France that showed, without a placebo or a control arm, showed that there was some clinical benefit when the drug was combined with an antibiotic called azithromycin. And that set off, especially because there was nothing else that seemed to be working, it set off a lot of interest and, frankly, a lot of activity around hydroxychloroquine. The drug started being used in a variety of settings, and from those settings, not only did we design some appropriately designed phase 3 type studies to actually look, is it safe and effective, but there were outcomes from registries and large cohorts of patients who had been put on hydroxychloroquine with some somewhat conflicting results compared to the original pilot study. And you can see that there was both a VA study and a global registry. Both of them have flaws within their own designs, but in general, what they didn't see was a significant clinical benefit, and there was a question of potential safety concerns. As of today, I also put on there the WHO trial, which was temporarily halted because of some of those. But actually, even when they reviewed these data, they've actually reinitiated the study to truly understand, along with the NIH study, is there a definitive answer about the risk-benefit of this study? I think what is so important is that right now, the data, the wealth of the data doesn't seem to support a significant benefit. I think importantly, there are 2 studies that are underway that really will help us understand in a well-designed trial where this drug belongs in the treatment paradigm. But as of yet, the data is not super strong to support it. Next slide. So kind of highlighting, there's been a perspective that if we have nothing else, we should maybe just try this. And that, I think that's one perspective you can take on this, but the drug itself is not without risk. And most importantly, I think it's not without risk to patients with underlying liver disease or other medical complications. As I said, the larger studies really have not shown the potential benefit that was seen in the smaller trial. I think what's really important, and there was a study that just came out today, that there doesn't appear to be any data to support that taking it prophylactically to prevent the infection, and the study that came out today that says taking it after you've had a high-risk exposure doesn't do anything. So there is absolutely no data to support that that this will prevent the infection either before you get it or if you've had an exposure. And I think that's important because there's a lot of media attention around the use of it in that capacity, and it really is not supported at this point. I think why it's important to think about as a PSC patient is there are some significant potential toxicities. The drug is known to cause cardiac arrhythmias or irregular heartbeats that can sometimes be fatal. And often PSC patients are taking other medications that may interact with that and even further enhance that potential risk. Hydroxychloroquine generally in a healthy patient with a healthy liver or a patient with a healthy liver doesn't cause hepatic injury, but we've now seen the drug does accumulate in the liver. And so if you've got underlying liver disease, there is a risk, and we're starting to see some cases of hepatic injury in patients with potentially liver disease. So it's not a good reason to take it. I think also for transplant patients, there's a risk because it does interact with both cyclosporin and tacrolimus and can cause those concentrations of those medications to go up significantly and cause some toxicity. So I think the general perspective, despite all the hype, most of the medical experts, the guidelines, and the research that's being gathered to date say that really it shouldn't be used in the routine setting, especially not for prevention or prophylaxis. And if it is going to be used, it really should be in the context of a trial or in a hospital setting where somebody can be very closely monitored. So I think this is sort of the framework of hydroxychloroquine. Cynthia, how is it being played out in Miami? You know, you're obviously a very state-of-the-art center, have transplant patients. What's going on with hydroxychloroquine in your perspective down in Miami?
I think the literature really does not support its use. It fell off of our guidelines, our algorithms for management of COVID. So we don't use it.
Even in, like, say somebody's really sick in the ICU, that it's not even being
applied? There are other drugs that we're using, not hydroxychloroquine.
Okay, that's good from that perspective. Gideon, I know the other day you said there was still some use up in Canada, but what are your thoughts on it?
I don't think so. It doesn't work. I wouldn't take it myself. I think it's an interesting lesson in optimism and hope. But anyone who understands the virus and the heterogeneity and how it presents never really believed it was going to be this magic bullet. And as Cynthia says, there's better progress in other places. So I wouldn't take it and I wouldn't prescribe it to a patient.
I think that seems to be the broader consensus, and hopefully, I think if anybody is considering it, I think it's important to absolutely talk to your physician and your PSC specialist about it, and you would need to get access. But I think, again, it sounds like the pendulum is swinging back, but we will wait to see the final studies that will help us make that final conclusion. Catherine, next slide. So now we're going to move to where there is at least a glimmer of some positivity, and this is a drug that actually had been developed for other viruses called remdesivir, and it's an injectable drug that was tested actually for Ebola and showed very early on some potential activity, at least in animals, that the drug may actually work against COVID-19. Now, there was a long period where it was being used for compassionate use while several phase 3 studies were being designed, and there were some positive outcomes from those studies that have been published, giving some inkling that the drug may actually have some potential positive activity. The good news is that with the power of the company developing it, Gilead, and the governments, and most importantly, the investigators and patients, the results of actually three well-designed trials have provided us with some insights that at least give us some sense that the drug may have some positive effect. Now, what's interesting is it doesn't look like it drops the viral load very rapidly. So it's unclear to understand how it's actually working. But at least in these studies, the general things that have been seen is that there doesn't seem to be a big improvement, at least in clinical events or mortality, but it does decrease hospitalization time. So there does appear to be some positive movement in shortening the course of the infection, and especially in severe patients. The other aspects that they've seen is now that there's some newer studies that are coming out showing that it actually may have a better effect, which if it's used earlier, and that would make sense that it's sort of being used when the virus is the main problem, as opposed to when it moves towards maybe the cytokine or the lung injury, where the virus may not be dominating what's going on in the patient at that point. The other good thing is it does appear only a course of 5 days. If it's going to work, that should be sufficient. Since it's an injectable, that does make it a little bit easier, especially if we're going to go into patients who may not be hospitalized or may be earlier in their hospitalization. It does appear relatively safe, although there have been some initial cases or concerns about rare cases of liver injury, but given the short course of therapy, it doesn't seem to be something that couldn't be monitored. And it is approved for emergency use. Now, I think that's something that I'll highlight here in a second if we go to the next slide. So as I mentioned, it is approved for emergency use authorization. I think it's important to understand that that doesn't mean it has been fully approved like the way a drug normally is for the FDA. It's been identified and the data has been provided to the FDA to say, okay, you can use it in a very specific population. But there is no formal review to say the drug has been sanctioned or fully approved as safe and effective. That being said, in pandemics and things like this, these emergency use authorizations are important to get access, but it should be clear the drug is not fully approved, and so it needs to be used very specifically in very unique, targeted populations. It is only approved for patients in the hospital who have severe infection. This may expand based on even some recent data. I think overall, the perspective is that it's at least a step forward, but it's a modest one at best. But it's a good step to maybe build on for the future. And we may see that if it's used earlier, we may see better outcomes. But I think the biggest hope is now that it can be combined with other treatments, especially in the sicker patients, that may bring around even better results that are more hopeful for patients at this point. So a good first step. But I think the terms game changer and it being the silver bullet, I think, are a little overestimating what the information shows. Cynthia, are you guys using, have you had any experience or exposure to remdesivir in either the PSC patients or any population down there?
Not with PSC patients, but yes, we're using this for all the moderate and severe cases of COVID at our hospitals.
Yeah.
It has to be an individual basis for the approval because it's only for emergent use. So we don't have it in bulk. We have to request for each case.
Okay.
But yes, we're using it 5 days as recommended, and we try to use it early. So not just the severe cases, but
Not
also the moderate ones who are not intubated yet.
Okay, so you've moved to sort of based on the data to try and treat earlier then. Okay.
Yeah, before we were giving this just to the severe patients, and now we're trying to start a little earlier.
Okay. Gideon, how about Toronto?
Well, I'm not involved. My understanding is that it's a mixture of putting patients into ongoing clinical trials, but a similar approach to Cynthia. Again, as I said, I'm a pragmatist. If I had COVID and I required hospitalization, then whilst it's definitely not a silver bullet, I agree I'd take remdesivir for 5 days. I don't think it benefits you once you get so sick that you're on a ventilator, but there does appear to be a window where it's contributory. But it's not a panacea, and it's never been easy to develop drugs. I think you'll know this for viral diseases.
Yeah.
And we've always made incremental steps and understood it. And we're so early in this pandemic, we don't know how to risk stratify. What that means is we don't know who's going to do well and who's going to do badly from the minute they're positive, which makes the study design very difficult. And I think the other way I'd say is, yes, it's positive and yes, it's optimistic. But remember, if you need a study with thousands and thousands of patients to show a difference of a few days reduction in hospitalization, you can see that it's not the silver bullet that you want, but it's a step in the direction.
Yep, I think we're all in agreement, and I feel much more comfortable that this has been studied appropriately compared to hydroxychloroquine, at least at this point for the data that's being used. So. Okay, great. Well, let's move to the last topic, which I think is important, especially for PSC patients, but frankly for all of us, which is vaccines. Similar to drugs, there is a flurry of vaccine activity that has never been seen, even with things like Ebola. As of, again, yesterday, there are 95 vaccines that are being studied globally, many of them here in the US, but many are in countries where they're not studying it here in the US, like China and India. A good thing that will help us is that many of these are established methods that have been used to develop other vaccines or are basically sort of deviations of other vaccines. So we have some knowledge about how they work, how to make them, can they be produced in large quantities, things like that. But some of the more interesting and promising ones are brand new technologies, which may bring on better efficacy, but there's a lot of unknowns with some of those new technologies. So we'll have to see how things play out. But again, unlike anything I think any of us have seen, the movement to get vaccines available as soon as possible is key. It will be an important part in helping to manage both this first wave or this first pandemic and then subsequent ones. Little bit of difference between drugs. There isn't going to be likely an emergency use authorization. They're much stricter about how vaccines get used, and so there will be trials, but these trials are going to have thousands of patients, the phase 3 trials, and there will unlikely outside of a trial be made available the vaccine, except maybe in extreme emergent situations or high-risk situations, but even that is unlikely. There's been a big debate as to when this can get done. The experts say don't count on anything between 12 to 18 months, and I think if we're trying to be conservative and be realistic, that's probably a good time frame to think of. There is everything being done to try and make shortcuts here, but those shortcuts are also raising concerns. Do we end up with a vaccine that isn't as effective or has potentially safety issues? So I think we have to be careful in our estimation that if somebody says it's going to be available at the end of the year, do to be, is that the vaccine you want to take on the first go round? So I think it's going to be really important to have a good discussion with your physician about which vaccine to take. When is the right time to take it? We're all anxious for it, but with so many different ones being developed, I think it's going to be a really important thing to have a good understanding, because this is not like, this is the first time for a vaccine of this type. Next slide. Couple things to keep in mind that I kind of highlighted is that the first vaccine available may not be the best or the safest. So again, have those important discussions with your care providers. The one thing that we don't know yet is, we know, for example, flu vaccines can be anywhere from 40 to 70% effective depending on the year. We have no idea what the rates of immunity from these vaccines are going to be, because this is the first time we're seeing it, and different vaccines may be more or less effective. So there's a lot of unknowns there. We don't know if it's a one-time vaccine, but it's unlikely that it will be, and that it's going to be at least probably on a semi-regular basis. But again, that's going to have to be studied. And I think the one thing that I want to emphasize is, just because a vaccine gets approved, it then has to go through the whole rollout and making accessible to everybody. And we may see an approval, but Gideon and Cynthia may not be able to give it to their patients until 6 months later, depending on if they're high risk or not. There's going to be a lot of discussions about how this rolls out. So just be prepared that even if we have a approval by the end of the year or early next year, it's another 3 to 6 months before maybe the average person is going to get it, or somebody who isn't high risk. I think one thing that I always emphasize, and it's maybe my bias, that there are vaccines out there that can help prevent other medical complications that could make this worse if you do get COVID-19. And I'm a big proponent to say, stay on top of your other vaccines that can help you not get other infections. But yeah, Cynthia, how are you talking to, because I'm sure you guys are getting a lot of questions about when's the vaccine available? When am I going to, what are you telling patients?
I think you hit all the important points. I still think it's far away, and just relying on that is unrealistic at this point. So we have to follow the right precautions. I agree with other vaccines, influenza and pneumonia. We have to do those to minimize severity. Even if you get COVID, decreases the risk of you getting a bacterial pneumonia on top of it, anyways. And that's it. I agree. We can't rely on it. It's too far away. Yeah. And we have to find the right antigen to develop the vaccine against. Then we have to determine efficacy, and then we have to determine safety, and then long-term effectiveness. So it's a long way to go, unfortunately. Yeah. Even if right now there are thousands of patients being tested, it's being vaccinated, it's way too early. We just have to deal with that.
Yeah. I had a couple patients ask, actually, is there any concerns about a PSC patient participating in a vaccine trial? What are your thoughts on that?
Not that I can think of.
Only if, no one would go in a vaccine trial if they're immunosuppressed, unless that
if you're on medication, yes.
Yeah. Unless that trial was designed for a very high-risk population. So broadly speaking, all vaccines are less effective if you're on a prednisone dose of about 7.5 milligrams or higher, and biologics may change your vaccine response. But all those trials will have individual criteria, and if you meet them, you can consider it. I would agree with Cynthia. I'm optimistic there will be a vaccine. I'm just realistic that it's going to take some time before it's safe, can be widely disseminated, and there will be a choice of vaccines, and we'll learn. And it isn't the solution for the next 12 to 24 to 36 months. But this is not the year to miss your flu shot.
I think we're all in agreement with that.
The outcomes are all based on how busy hospitals are.
Yeah.
You're doing your service by not getting influenza.
Yeah. I think we're kind of we're getting to the end where we need to wrap up here. This has been great. I know there was a section we were going to talk about clinical trials and kind of what's being done. I think what we'll do is we'll take some of those questions, and we're going to take a lot of the questions we didn't get a chance to answer or that come in, and we'll generate responses and post those. But I think just at a high level, I think you both would agree that clinical trials are starting to get back very similar to the clinic. They're getting back up and running, and a lot of the precautions to ensure safety and good conduct are being put into place by both the sites and the companies. Is that a fair assessment? Okay.
Absolutely.
PSC remains very important, and the trials will be relaunched with extra vigor and with precautions about COVID, so they're COVID proof.
Yep.
Yeah.
Great. I think, first of all, thank you both so much for the time, the conversation, your insights, the banter between the two of you and the differences, which is, I think, important for people to understand. There's a wide range, but it's also, I think it's clear you both have, I think a same good vision on how to move us forward. I think we're going to turn this over to Mary, who's going to cover, I think, the last part, which will be the survey that we've done. So thanks again, both Gideon and Cynthia. And
Thank
Mary,
you.
I'll turn it to you.
Thank you.
Thank you, Steve. Catherine, can you put up the slide, please? So we're going to be talking about the COVID-19 and PSC patient-reported survey that PSC Partners launched. In late March, we saw that several registries were launched to collect information on COVID-19 and chronic liver disease. However, we did not see anything that would collect PSC-specific information. And with the goal of being able to look specifically at what we could find out about the experience of PSC patients with COVID, we launched a patient survey. The survey has been reviewed by an institutional review board, an IRB. It can be answered without providing any identifying information, and we'll be publishing periodic aggregated updates on what is submitted. So the survey was launched in late April and has been active now for approximately 6 weeks. And this is the first update we're giving on the data. You can see in the top right of your screen a tiny box with a bunch of data. That is a summary of what's been collected, and we will make that available in a legible version. But tonight I just wanted to give sort of a little overview of what we've seen. So thus far, we've had 19 responses from individuals who are PSCers and who suspect having or were diagnosed with COVID-19. Of the 19, 6 were either tested positive or were diagnosed with presumed COVID-19 by a healthcare provider, and the other 13 did not take a test. So I'm going to report here just a little bit about the group of 6 who have a diagnosis of COVID, but the other larger group is not remarkably different. So basically, just some quick information, 50-50 men and women. Of that group of 6, they're from 2 countries, US and Sweden. The age ranges between 35 and 75. The medications reported prior to COVID were steroids, urso, and no biologics in this very small group. 2 had an underlying disease other than PSC, IBD, or autoimmune hepatitis. 1 was post-transplant. The reported symptoms were consistent with what we would expect from what we're hearing about COVID: respiratory, increased fatigue, GI, fever, eye problems, loss of smell and taste, aches. None received investigational treatment or antibody tests. In terms of PSC-related complications, there were not many reported at all. Increased fatigue was reported, and 1 patient reported cholangitis. Most importantly, only 1 was hospitalized, and none were put on ventilator, and all have recovered. So if you'd like to see the details of the data that we've collected thus far, we will be making that available. But in thinking about what we can learn from this small amount of data at this point, keep in mind this is a patient-reported survey. All of the other surveys that we know of or registries are physician or institution or formal studies. And while the numbers are too small to draw any conclusion, it does seem that this is good news. We're seeing nothing on social media that contradicts the small numbers that have been reported in the survey. We're all hoping that the clinicians are seeing the same and that we'll continue to see the same as everything opens up. So please, if you have been diagnosed with COVID or you suspect having had COVID, please go to the link on the screen, which is links.pscpartners.org/COVID survey. It takes 10 minutes to complete the survey, and we would appreciate it. And I'm going to say that it's almost 8:30, and I think that's all the time we have for this evening. So thank you, and good night from me here in Toronto, and a sincere thank you to all of our speakers. And I'll hand it over to Ricky.
All right, yes, I know we went over, but there was so much wonderful information and talking back and forth, we didn't want to cut everybody off. So I just want to thank you so much, Drs. Hirschfield, Levy, and Rossi. You offered us so much wonderful food for thought and great practical information and advice to help us make difficult personal decisions during the pandemic, and especially this crucial time when everything's starting to open up. So for participants who'd like to view this presentation again, just repeating one more time, the recording will be available on the website, the slides will be available separately on the website, and the 3 speakers have kindly offered to answer questions that weren't covered. To end up, I'd like to make a personal reminder to our community to continue safe practices, washing your hands frequently, practicing physical distancing, wearing masks when you go outside. We all need to protect ourselves and others around us from becoming infected. We are much saddened by these times of crisis, and as we all work to solve the problems out there, PSC Partners will continue our mission to educate and support our PSC community. Please stay in touch. Thank you all for joining us tonight.